this is yellowing of your skin. Hello. Yeah. So jaundice is your yellowing of your skin. Okay, and it can be divided into three causes. Okay, according to the level of obstruction or problem you have inside your liver. Okay, this is first point. Another point is like, why do you see this yellowing of your skin? Because of this bile pigment. Okay, because of this bile pigment. And where does this bile pigment comes from? Your liver synthesizes your bile acid. Okay, and your bile acid is composed of bile salts and your bile, you can say cholesterol stones, or you can say things like this. Like a cholesterol component is always there. And if because of some reason your bile acids are decreased and cholesterol component increases, you develop gallstones. Just a brief overview of things, and I hope this is clear. And now we will talk about the causes. Okay, so like there are three causes. You can see unconjugated hyperbilirubinemia, which is very equal to indirect jaundice, like indirect bilirubin elevation. Okay, and then you can see the same thing, unconjugated bilirubin, and then you have conjugated bilirubinemia, which is also known as direct bilirubin. On your lab work, in your questions, you find these words. Okay, these are interchangeable words, mean the same thing. Now, if I say unconjugated hyperbilirubinemia, what do I literally mean? It means that your liver cannot conjugate your bile. Okay, that's why it's unconjugated hyperbilirubinemia. Okay, so this means you are either producing more and more bile that the liver cannot metabolize, cannot conjugate, okay, which happens when you have hemolysis. So whenever you see hemolysis, one of your cause of your indirect or unconjugated hyperbilirubinemia is your hemolytic anemias, okay, intravascular, extravascular hemolytic anemias. For some reason, if you have hemolysis, you can see indirect hyperbilirubinemia, okay. If you guys are getting my point, you could just say okay or something, like once someone can say it so that I understand you guys are understanding this thing. Okay, and um, hello.
Yeah, we are
Yeah.
getting.
Yes, we are getting your
Yeah,
point.
yeah, okay. Yeah, okay. So after this, you have mixed. In mixed type, you have direct and indirect both. It means that the problem is inside the liver itself. It's the problem is not with the destruction of your RBCs. It's the problem is not with the conjugation of the RBCs. The problem is within the liver itself. That's why we name it as a mixed hyperbilirubinemia or mixed jaundice. Okay, in which your unconjugated bilirubin, indirect bilirubin, or your conjugated or indirect bilirubin both can be raised in equal amounts, you can say roughly. If you see isolated direct bilirubin elevation, it is because of your post hepatic causes. Your post hepatic causes basically involve your biliary tree for some reason. It means your liver processed everything, like your liver processed your bile acid, made it, and now it's time to be excreted. But when you're excreting it, you have stones here in the gallbladder and the pancreas, or some kind of obstruction, some kind of tumor, some kind of autoimmune disease, inflammation, stuff like this. That's why you are seeing a direct bilirubinemia. Okay, I hope it's very very clear. And on your exam, how will this help you? It will help you to rule out and rule in the disease based on what kind of bilirubin is elevated. If you see a mixed picture, you can think of hepatitis, like viral hepatitis mostly. Okay, if you think of conjugated bilirubin, you can see especially gallstones, pancreatic cancer, cholangiocarcinoma, primary biliary cholangitis, stuff like this. If you see unconjugated bilirubinemia, it's because of hemolysis. That you must keep in mind. Okay, I hope it's very very clear. If it's clear, we can move ahead. Okay.
It's clear, yes.
Clear.
Yes. Yeah. So okay, good. So now, just a thing, there are a few questions on this that I have seen. They like to ask that in neonates, if you see increased unconjugated bilirubin in neonates, if you see increased unconjugated bilirubin, why do you see that? What do you do about this? You have to keep this in mind. You can see physiological jaundice. Okay, physiological jaundice. And physiological jaundice is because when your newborn is surviving, it has increased RBC turnover. Okay, it has increased RBC turnover because of the hemolysis. As I told you, your unconjugated bilirubin increases, right? And then you have another cause for this physiological jaundice is that your liver is actually immature. Like the enzyme that conjugates your bilirubin, that is no that has a very big name. I won't recommend that you remember it, but it's something like UDP, glucose transferase, or something like this. Okay, just keep a rough idea of the enzyme name, but you do not need to remember it as such. But anyways, UDP glucosyl transferase, okay, that is the enzyme that helps with the conjugation. When you're newborn, like in newborns, this enzyme is immature. Like your liver is just preparing to begin to survive in this life, right? So it's taking time. It's not so mature to handle the stresses of the body, like handle the stresses of your RBC destruction that is going on, like a normal thing that is going on. So that's why you can see again unconjugated bilirubin that is high in amount. But this all is physiological. Why do we call it as physiological? Because it's really physiological. It will resolve on its own. It should resolve on its own within 10 days. If it does not, then there is a problem. Okay, this is first point that you have to keep in mind. They can ask you the causes. They can ask you if it's benign, what do you need to do, stuff like this. Especially like this is very, you can say their favorite topic to test you with neonatal jaundice. Okay, last reason that you see in neonatal jaundice is because of the beta glucurosidase, that is your GI enzyme. Like your bilirubin, of course, when it's excreted, why do we see jaundice? Because your bilirubin is not made, or either it's not excreted. So if it is made, and normally when it goes into the GI tract, it's excreted into your feces and urine and stuff like this. Most of your bilirubin is excreted in feces. Okay, if for some reason you cannot excrete it, you can see this pale stools and stuff like this. So there is a classic presentation. Whenever they give you conjugated bilirubin, they will describe as pale stools and your colored urine. They will always describe it like this. Whenever you see these words, close your eyes, go with your conjugated bilirubinemia causes. Okay, this is first point. Another point I was telling you about beta glucurosidase. This is a gut enzyme that helps, like if it is increased in amount, okay, it leads to a lot of deconjugation of your bilirubin. Like in your gut, you can actually deconjugate. Like in liver, we are conjugating your bilirubin. In your gut, you can actually deconjugate because of the presence of this enzyme. Normally we have minor, you can say, activity of this enzyme, and there should be minor activity of this enzyme, not too much, because if your bilirubin is deconjugated, it can be absorbed, and if you absorbed it, you can get hyperbilirubinemia. This is another point. They can ask you these things. You need to remember three causes of physiological jaundice, and since it's physiological, it will resolve on its own, and you do not need to worry about it. I can speak more on this neonatal jaundice, but to keep it precise, I'll stay till this point. And if someone has some questions or something, we can discuss it anytime. Okay. Uh, this was your jaundice part. Okay. I hope these causes and all this stuff is very clear to you, because this is very high yield. This helps you to understand liver pathologies. Okay.
Please,
And
can you
now we
recap
will.
the physiologic jaundice,
Uh,
please? Mm.
Sorry, can you repeat it again?
Yeah, the physiologic jaundice. Yeah.
And the last part to the unconjugation in the intestine, please. Thank you.
We can't hear you.
Hello. Okay, so okay, I think there is some issue. She's joining in a while. Just wait a second, okay?
Hello, can you hear me?
Yes.
Yes, we can hear you now.
Hello?
Yes.
Yes, we can hear you now.
Yeah, yeah. So someone was asking the question. Can you can ask that?
Yeah, I was asking if you can please repeat the physiologic jaundice.
Yeah, sure. So physiological jaundice, as I'm telling you, like physiology is a normal thing. So this jaundice is seen in neonates in the first week of life, and it's a normal thing. You do not need to do anything about it. I don't know how many people in you know, like how do you treat the jaundice. That will be another topic. That's why I've said I'm not going into details. But like we can discuss it some other day, but for now you need to know that physiological jaundice is there in the neonates. Why do we see physiological jaundice? Because of three reasons. Okay, first is your decreased RBC lifespan. Okay, it means your RBCs will be destroyed more and more, and because if your RBCs are destroyed more and more, you have heme component. That heme component is basically converted into bilirubin. Okay, so you will make more and more unconjugated bilirubin. This is the first reason that you see physiological jaundice. The other reason that you can see physiological jaundice is when you have immature liver enzyme, that is UDP, glucosyl transferase. Okay, this enzyme basically conjugates your bilirubin, and if you cannot have activity of this enzyme, it means I cannot conjugate my bilirubin, and my unconjugated bilirubin levels will be high. Okay, this is first point. I mean second reason, and the third reason is that your beta gluconosidase. This enzyme is present inside the gut, and this enzyme loves to deconjugate your bilirubin. Like if I say this is conjugated bilirubin, it loves to unconjugate this bilirubin. Like inside the gut, normally you have some expression of this enzyme. And in neonates, for some reason, if this enzyme activity is increased, it can convert your conjugated bilirubin from your liver. It went into your GI tract and it became conjugated in your liver, right? Normally. And when it went inside your gut, normally it should not be unconjugated by this enzyme. Normally it should not be this like this. But in kids or in children, sometimes what happen is that beta glucosidase, the activity of this is increased, and that's why you see more conversion of conjugated bilirubin into unconjugated bilirubin. And if this happens, it can lead to absorption of bilirubin again into the system, and if it's absorbed in excessive amount, it can of course lead to jaundice. So I hope it's very very clear. Now you are not confused.
Yes, thank you so much.
Okay.
Yes,
I have a
Okay. All
questions.
right.
So
So
thank you
I
so
have a
much.
questions.
yeah, no
So
worries. Yeah. Yeah.
the physiologic
Mm-hmm.
jaundice is a jaundice
Hmm.
increase the unconjugated bilirubin, right? Jaundice is a increase the unconjugated
Yes,
bilirubin,
yes,
right?
yes. That's another high yield point to keep in mind, that in neonates you will see most of your bilirubinemia is because of unconjugated bilirubinemia, not because of conjugated. If you see conjugated bilirubin that is elevated, then it becomes biliary atresia. This is more detailed thing, and for today, like Dr. Ahmad told me, like I have to tell you about the liver pathology, so I'm not going into detail. But if someone is very interested, then I can ask Dr. Ahmad whatever he says. I can like tell you guys. But for step one, do you need to know this? 50-50. But for step two and step three, definitely you need to know this. Okay. So, anyways, we will stick to step one. Okay, we will try to stick to step one first on the like basics of step one. Okay.
Dr.
So this is another
Dr.
thing. Yeah.
Yes. Please share your screen.
Yes. Did you say something? Yes. Oh, my screen was not on share. Yeah. Can you see my screen?
Yes, we can see it now. Yes, we can see it now.
Yeah. I hope we are clear with jaundice part. Okay. And now we will discuss about cirrhosis. Okay. For cirrhosis, I want you to understand cirrhosis is fibrotic degeneration of your liver cells. Fibrotic degeneration of your liver cells. Okay. So what happens is your liver basically has a lot of functions. I want you to keep these functions in your mind. Liver synthesizes your albumin. Okay. Liver makes your coagulation factors. Okay. And liver helps with your platelets too. And for some reason, if your liver is damaged, you can see thrombocytopenia too. Okay. And what else? It helps with detoxification. You need to remember this. These are the functions of liver that are very very important. Okay. And what else? These are few things that you should always keep in mind. Okay. And it helps with estrogen metabolism. Okay. These are all the main and important functions that you should keep in mind. And if I say cirrhosis, it literally means like instead of having this normal tissue, like this is your normal tissue, there are zones of liver, zone 1, zone 2, zone 3, and this is your central vein. And then side at the side of your central vein, you have this porta hepatis, which has this portal triad. You have bile duct, you have you can say that hepatic artery and stuff like that. So you have this combination of these three things: artery, vein, and bile duct. Okay, and in center you have central vein, which again empties into IVC. Okay, so what happens is this is your normal liver parenchyma. Now, if this becomes fibrotic, on histology, how can you pick fibrosis? Is this pink deposition? If you see this pink deposition, it literally means like anywhere, like apart from the liver, if you see this in kidneys or somewhere else, if you see this light pink deposition, it is always going to be fibrosis or sclerosis of something. And fibrosis and sclerosis literally means like a collagen deposition, acellular thing, like a proteinaceous deposit that is there, and it's afibrotic, acellular. I hope this is very very clear. This is just a histology finding that you have to keep in mind. Okay, so whenever you see cirrhosis, you see that this pinkish deposition or this collagen fibers are highly present in your liver histology. Instead of these normal cells, if I say this is one cell, this is another cell, this is another cell, this is another cell, these are all normal cells. And how different is this histology from this? It's very obvious. You see distortion here, you see a complete distortion here. Apart from this, you see this white thing happening. We will talk about it in just a second, but I hope this thing is clear. So this is your cirrhosis. This cirrhosis is your fibrotic replacement of your normal liver cells. Okay, okay. And when you have cirrhosis, it means your liver cannot do its functions. And if liver cannot do its functions, you will see uh, actually, yeah, so you will see hypoalbuminemia. Okay, that's how you also regulate your liver prognosis when there is cirrhosis of your liver. Okay, you can also see that people cannot metabolize their estrogen. Okay, and because of no metabolism of estrogen, they can develop spider angiomas. Okay, they can develop spider angiomas. And the males can have testicular atrophy, and there's gynecomastia that can happen in cirrhosis. So all these symptoms are related to the function of your normal liver cell, like your normal liver itself. If you do not synthesize your coagulation factors, of course what will happen, you will bleed a lot, right? So this is all your cirrhosis, the main chunks I have told you. Especially they love to test cirrhosis a lot. Cirrhosis and its complication, they love to test this thing. They love that you understand this concept that your estrogen is related to your that thing, to the presence of spider angiomas, gynecomastia, and testicular atrophy. Okay, so this you should keep in mind. And after this, like what conditions can lead to cirrhosis, this is also another important point. Oh, one more thing before I go. As I told you, detoxification is another function of your liver. Like normally liver does the detoxification. So if you cannot detoxify, your urea cycle takes place inside the liver cells. Okay, and your urea cycle basically helps you excrete ammonia. Okay, it helps you excrete ammonia. And if you cannot excrete your ammonia, it is excitotoxic to your brain cells. It excites your brain cells. This is your keyword that you have to remember: excitotoxicity, because of hyperammonemia. Okay, and because of this you see hepatic encephalopathy, and because of this you see this aesthetics, like flapping tremors, that can be seen in cirrhotic patient. These are very diagnostic point for your cirrhosis. So I hope it's clear. If it's clear, we can move ahead. Just someone can say it, like they're very, like they're understanding this thing.
Yes, we are understanding. Thank you. Yes, we are understanding.
Okay.
Thank you.
Yeah. Okay. So after this, I want you to remember this was your cirrhosis. Now we will talk about causes. But before we, actually, we can firstly talk about causes. So causes of your cirrhosis, if I were to name, there are so many causes of your cirrhosis. First, you should always keep in mind hepatitis B and C, because they can develop into cirrhosis. There is a journal you can say flow thing, or journal rule. You first have acute hepatitis, then it goes into chronic hepatitis. From chronic hepatitis it goes into cirrhosis. From cirrhosis it can go into hepatocellular carcinoma. This is how you can develop liver cancer from any kind of reason, whether it's hepatitis B, C, whether it's your alcoholic hepatitis, whether it's your non-alcoholic hepatitis. whether it's your autoimmune hepatitis, hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency, like anything. Acute hepatitis, chronic hepatitis, cirrhosis, hepatocellular carcinoma. This is how it progresses. This you have to keep in mind. Okay. And if I say from hepatitis B and C, which which viral infection has more tendency to go into cirrhosis and convert into cancer, it's hepatitis C. Most of your infections with hepatitis B, 95%. Sorry, someone said something. Yeah. So I was saying 95% of your hepatitis B infections, they resolve. Okay. They resolve. They do not go into cirrhosis. Okay. So I was telling you about the causes. The one and the most important cause is your hepatitis. Is your hepatitis. Okay. Then alcohol. Don't forget your alcohol. Alcoholic liver disease, very common. A lot of questions on this. Then you have these autoimmune hepatitis. Okay. And then as I just told you, this primary biliary cholangitis, primary sclerosing cholangitis. So I'll just write cholangitis. Okay. Cholangitis is your bile duct inflammation. It's a bile duct inflammation. Okay. And then you have hemochromatosis, then you have Wilson disease. A lot of people actually confuse these terms: cholangitis, cholecystitis, choledocholithiasis, biliary colic, and stuff like this. We will talk in detail about this. But for now, I want you to keep this in mind. Cholangitis means bile duct pathology, like a bile duct inflammation, like common bile duct inflammation. Okay. And and you guys know this, that hepatic duct and cystic duct, they both come together to form this common hepatic duct. Okay. Common bile duct. Okay. So I hope it's very clear. These were your causes. Okay. what what is the consequence of cirrhosis? You can say, if I were to say, you can keep this thing in mind, that this liver has become cirrhotic, right? It means it has shrunken in size. Okay, it has shrunken in size. And if I say that in the mid of this you have central vein that is sitting there, and if I say this whole thing has compressed or shrunken in size, it means it will increase pressure here, correct? And if it increases pressure here, it will increase your pressure on the arteries that are joining this duct, right? Okay. So what happens is that, I want you to keep this picture in your mind, is that this is your liver. Okay. Just an illustration. Okay. And here you have portal vein. I'm making it big, but it's not that big. So you have portal vein, and then here you have central vein and hepatic vein, stuff like this. Okay. So if your liver has shrunken in size, okay, it has shrunken in size, it means it will compress this area, and your pressure here would increase. It means if pressure here increases, the pressure will backflow, and you will see high pressure here too, in your portal vein. Okay, in your portal vein. And you know that your portal venous system carries your blood from your GI tract to the liver to first detoxify the, you can say, toxins, any kind of nutritional, like any kind of substance that you ate and is very harmful to your body, or any kind of drug that you ate, it is metabolized by the liver, right? So from your gut, like this is your gut, suppose, and it sends the venous blood to the liver in the form of portal vein, or in the form of portal venous system. Okay. And this blood is first metabolized by the liver, where you have metabolism of a lot of your toxins, you detoxify everything, and then it is sent to the hepatic vein, and then it drains into the IVC. This is one of your question that they can ask you. They want you to understand this whole track thing. There are a lot of question on this track thing. Okay. So I hope it's very clear. And I was telling you about cirrhosis. Okay. So one of the consequence of your cirrhosis is that your portal hypertension can develop. Why portal hypertension? It, like, what does this literally mean? Your portal vein has a lot of, you can say, vasoconstriction or high vascular tone. That's why it's portal hypertension. And why would you see portal hypertension? Because of cirrhosis. And now we understand why do we see this thing, because this whole thing is compressing on its own, and because of compression it increases pressure here, and then you have the backflow of the pressure, and you increase the pressure inside your portal vein. I hope it's very, very clear. If you all are clear, I can move ahead. Okay. Hello.
Yes.
Yeah, yes.
Yes.
Yeah. Okay. So after this portal vein thing, you need to understand that this portal vein, as I told you, this is your GI tract. Maybe for suppose this is your esophagus. Just for illustration, this is your GI tract and this is your rectum. Okay. Your first venous drainage, second venous drainage, and third venous drainage, they all drain into this portal vein. And we know because it's cirrhosis, you have high pressures here. It means you will transmit this pressure to these veins too. Okay, same for this one, same for this one. I hope this is like very clear, correct? And if you transmit this pressure back to your gut veins, right, you can develop varices. Okay, this is highly tested topic. They want you to understand this esophageal varices. Okay, so what is esophageal varices? It's like you bleed from your esophagus because of this portal venous hypertension. Okay, so what happens is you have increased hypertension here, and because it drains your esophageal area at your gastroesophageal junction, it can actually create more and more pressure here inside the vein, and it will rupture. If it ruptures, it can lead to bleed. And that's why you see people with upper GI bleed. One of the common reason for someone to present with this upper GI bleed is esophageal varices. You can see esophageal varices because of your portal hypertension. Okay, this is tested a lot. Like like portal hypertension, esophageal varices is their favorite topic for step 1, 2, or 3, like whatever the step is. Okay, and I want you to know, like as I told you, like arterial venous system, we have different names for all these things. So what vein drains into portal vein that supplies your esophagus? It's your left gastric left gastric vein that drains into portal vein. So if I say you are having esophageal varices, it means you will rupture this vein, correct? You guys are understanding this, right?
Mm-hmm.
Yes.
Yes.
Correct.
Yes.
Okay.
Correct.
Okay.
Yes.
Yeah. And then in your gut, okay, same goes for your gut, same goes for your rectum, but for some reason they like to test more about this thing. This I have told you, left gastric vein. And then you should remember, this I'm just telling you quickly, but how do you manage this? Propranolol, you give beta blocker to decrease the vessel tone. Okay, and you give octreotide. If someone comes with bleeding, the first thing I'll do is to resuscitate and blah blah stuff, like the main ABC thing, and then my main treatment would be octreotide, somatostatin analog. Somatostatin analog is inhibitory to all of the things inside your gut. Okay, I'll give that thing, and for prevention, I will give beta blockers. I'm just telling you superficially. We can go into detail, but I'm just telling you the important points. Okay, the other point I was telling you about this area, this central gut area, like around your umbilicus, this venous drainage also drains into your portal vein. So if you have portal hypertension, you have a high pressure here also. So what vessels lie here in your mid gut, or you can say around your umbilicus? It's your para-umbilical veins. Para-umbilical veins. Okay, and if you have like if you have severe portal hypertension, how can this present? It can present with caput medusae. Caput medusae. Okay, like for caput medusae, I would recommend that you can just Google the picture. It's like around your umbilicus, you see these blue dilation of vessels. Okay, this is known as caput medusae. Okay, and same goes for rectum. It's your superior rectal vein that you can see anorectal varices. They tend to bleed. They can bleed, but for some reason they do not ask much about these two things. I have seen they mention about caput medusae inside the question, but they do not have a specific question on this. They love to test esophageal varices because it's clinically more relevant. Okay, and then there just a concept thing that I want you guys to know is that uh, if I say this is your esophagus, this is your stomach or your gut thing, okay, and this is your rectum, okay, this is just an illustration thing. It has its own blood supply, correct? Because every organ or tissue inside your body needs a blood supply. So it has its arterial blood supply, and it itself has its venous blood supply, right? A systemic thing. It's like your machine also needs some kind of fuel. So for that machine to keep working, to make nutrients or to absorb food and to do this whole absorption thing, and then send it to the portal vein for the metabolism, to be like to all the thing to be metabolized by your liver. This is the purpose of your gut. Okay, and the purpose of your gut is to metabolize your food, absorb everything, and then send it to the portal vein, and then from portal vein your liver will metabolize this whole thing. This is the normal thing that is happening, but this machine itself needs its own blood supply, its own venous supply, right, for this machine to work. So what happens is your arterial blood is there. You can say your gut cells utilize your arterial blood. Now it is time to drain into your venous blood. So you have systemic venous system that is going on, right? And on these 3 points that I've told you, GI, rectum, and your esophagus, you have collateral, you can say collateral thing happening. I don't know if you guys know about collaterals. Collaterals is like one area supplied by uh, uh, more than one or two veins or arteries. Okay, so this one area, the gastroesophageal junction, is you can say it has a collateral of your left gastric vein and your esophageal vein. This is just for understanding purposes. Do not be confused. I'm just, the whole point that I'm telling you here is that you have collaterals. You have collaterals, and by collaterals I mean that your portal vein can come into contact with your systemic venous blood. Okay, at these 3 points only. Other than that, it is never in contact with the systemic venous system. Okay. I hope it's very clear for esophageal varices and you guys understand this thing.
Yes. Yes, it is. Thank you. Yes, it is. Thank you.
Yeah, yeah. And then I would like to tell you, I have told you about this whole thing. There's another complication of cirrhosis that you must keep in mind. It's SITs. Okay. So for SITs, I want you to remember it in this way, that SITs is abnormal fluid collection inside your abdominal cavity. Abnormal fluid collection inside your abdominal cavity. And what happens is that you have third volume space loss. What do I mean by third volume space loss? It's like just for your understanding purposes, this is your liver, this is your heart. Okay, and this is the whole system that is going on, just for your understanding. Okay, if I say you have 5 liters of blood inside your body, this 5 liter should go and keep circulating, right? You should have no losses. But when I say third volume space loss, this is also true for your cirrhosis, this is also true for your pancreatitis and stuff like this. So what I literally mean is that instead of this blood volume that should stay inside this vessel, it is accumulating outside the vessel in any area, right? Abdominal cavity has this you can say accommodation to accumulate this fluid thing. Okay, so that's why in cirrhosis patient they can actually develop ascites because of this splanchnic vasodilation. This is your one of your question in your U world in your exam. You could see this thing. They literally want you to understand this thing, like why do we see this thing happening. So your splanchnic vasodilation, like your vessels become very very leaky, and when they become very very leaky inside the abdomen, you see fluid accumulation that does not contribute to your arterial volume. That's why these people, even though you like that's why these people, they cannot maintain their pressures as such. Even though you give them IV fluids or something, some of their fluid will accumulate inside the abdominal cavity for some reason, and that's why you use furosemide as treatment, right? So this is your ascites. Whenever you have a fluid accumulation inside your body, like this is true for everything, it can be infected. It can be easily infected because inside your gut, especially, you have your own gut bacteria. Okay, so you can infect yourself with those gut bacteria. Another common question that you get is, what is the common bacteria that leads to this ascites? E. coli. Another apart from E. coli, Staph aureus. Okay, so you can develop now from your ascites. If you develop this infection, okay, so first we had cirrhosis. Because of cirrhosis we can develop ascites because of this vasodilation thing happening. Okay, and then if that fluid is infected, we name that disease as spontaneous bacterial peritonitis, because it's really the spontaneous thing. It happens spontaneously, like there is no source of infection that is there. It's just your gut bacteria that you can say migrated from your gut wall inside your abdominal cavity, and then they infected the fluid. Okay, so this is your spontaneous bacterial peritonitis. For this is also high yield spontaneous bacterial peritonitis, you need to interpret ascitic fluid, which we will do some practice questions, or like it will be more detailed, so I'll not go into detail. But in your ascitic fluid, you see high neutrophil count. Okay, how do you treat it? Fluoroquinolones. Simple as that. Okay. These three you should always remember: ascites, portal hypertension, spontaneous bacterial peritonitis, very high yield for step 1, 2, and 3. Okay, and so we have talked about cirrhosis, and what else I should tell you about cirrhosis? Mm, yeah, that's the most of your part that can be tested. Okay, now we can talk about alcoholic liver, like alcoholic liver disease. Okay, and if I say alcoholic liver disease, it's just your alcohol, because it's a we know, like, it leads to damage to your liver cells, right? It can damage your liver cells. So you see hepatic liver cell damage due to alcohol. And on histology, what will you see is this picture. Actually, this picture you need to keep in mind, this white vacuoles. Okay, white vacuoles, this is known as balloon degeneration. Okay, ballonic degeneration, or Mallory-Weiss bodies. Okay, so normally, if you see, it does not have this white appearance, like not like white empty spaces. But here you see a lot of white empty spaces, so it represents ballonic degeneration. For histology, on your for step one, I would recommend that you just need know the basics of histology. You cannot master this thing. There will be always one question with one histology picture that you cannot pick, and like, don't beat yourself for this. They give it very complicated, like they make it complicated. But of course you can get that question correct if you understand the disease very well, because whenever they give you histologies that are very difficult, they make question a lot easier. So even if you know something about that topic or something, you can pick it. Okay, and for, you can say, for difficult pictures you get easy questions, and for, you can say, easy pictures you get a difficult question. So yeah, they are like this. So anyways, I was telling you, yes, so alcoholic liver degeneration, we know alcohol leads to toxic accumulation inside your liver cells, and it leads to this balloon degeneration that you have to remember in mind, and it can lead to cirrhosis. You need to monitor them with ultrasound. This is all. And for alcoholic liver disease, the main thing that you need to know is the histology, if I were to say. Okay, now there is another disease, we name it as non-alcoholic fatty liver disease. Okay, for non-alcoholic fatty liver disease, it's the same thing that is happening. The cause is not alcohol, that's why it's known as non-alcoholic. That's why it's known as non-alcoholic fatty liver disease, because here you see the same histology, you see the same ballooning and stuff like this, but it's not due to alcohol. It's driven by your, you can say, metabolic syndrome, like your hyperlipidemia, obesity, diabetes, and things like this. Okay, and nowadays they have changed the name of this non-alcoholic fatty liver disease into metabolic fatty liver disease. Okay, like MEFLD. Okay, from NEFLD it has become NEFLD. So I hope you guys understand this thing. That's the only thing for these two disorders that you have to keep in mind. Okay. If you guys are getting my point, someone can just confirm it, and then I can move ahead.
Yes, yes,
Yes.
yes.
Yes. Okay. So then we have hemochromatosis. Okay. For hemochromatosis, I want you to remember this word hemo, like hemo means heme, and you know heme means iron pigment. So it's your abnormal accumulation of your iron inside your liver. And if inside your liver you keep on accumulating your iron, it's very toxic. And if you can say, it leads to abnormal liver function. It can lead to liver cirrhosis, as we have just talked about it. This is the main thing that you have to keep in mind. Another important point for hemochromatosis that you should keep in mind is how it presents. I have seen they like to ask this thing for some reason. Hemochromatosis, it's your mutation in your FE gene. This is also important. Okay, and how does it present? It can present with cirrhosis. It can present with skin pigmentation, that is also known as bronze diabetes. Okay, I'll tell you, bronze means a brown discoloration of your skin. Okay, and you can develop new onset, you can say, diabetes mellitus. Okay, you can develop these things. And what else should tell you? So this is your hemochromatosis. And yeah, another very important point that you should keep in mind for this is your gonadal atrophy, like your testicular atrophy. Because I just told you, if your liver is cirrhotic, you cannot metabolize your estrogen. If your estrogen increases, it leads to testicular atrophy. Can you guys just give me a second? I'll be back. Just a second. Okay. Yeah, so I was telling you about hemochromatosis. How does it present? I told you with liver, it leads to hepatomegaly and cirrhosis. For pancreas, I told you it can present with your diabetes, new onset diabetes mellitus. You should always keep this in mind. For skin, it can lead to this pigmentation. So this whole thing is known as bronze diabetes. Okay, like a skin pigmentation with your diabetes mellitus. Gonads is important. Hypogonadism, testicular atrophy, you can see this thing. Your iron can actually deposit between your between your joint. Let's like you, this is your if I say this is your one bone and this is your another bone, surrounding that you have synovial cavity. If you deposit iron here, you can develop arthritis too. Okay. And last but not the least, if you deposit iron inside your heart myocardium, you can see restrictive cardiomyopathy. This is also very high yield. Okay. So this whole thing that is happening is because of this mutation in HFE gene. This is also very important. They like to test this thing. This is your primary hemochromatosis, like because of a genetic defect. You can have secondary hemochromatosis in patients. They like to actually give this thing, that they can say that someone is suffering from beta thalassemia, sickle cell disease, stuff like this, and you need to transfuse them again and again. And normally our body has no way to excrete iron. Like our body cannot excrete iron. For females it's easier because of the menstrual blood flow, but for males it's not possible. Okay. So that's why hemochromatosis is more, you can say, prominent in males rather than females. Okay. And the other thing is, because you cannot excrete your iron from your body, you keep on accumulating it. If someone is having sickle cell disease or thalassemia, okay, and they receive the transfusion again and again, and when the cells are lysed, their iron is deposited inside the liver and leads to hemochromatosis and this whole thing happening. So I hope it's very very clear. And on your lab work, what you see is high ferritin levels, high iron levels, and stuff like this. How do you treat? Simple as that. What is the cause? Excessive iron inside your body. So you draw the blood, you do the phlebotomy. Okay, phlebotomy. And this is your hemochromatosis. Now we can talk about Wilson disease. Okay, for Wilson disease, I want you to remember it's related to copper. It's related to copper. Okay, it's a problem with this ATP7B gene. Okay, this ATP7B gene produces your ceruloplasmin. Your ceruloplasmin is basically a serum protein that combines with copper and helps in excretion of copper. Okay, and helps in excretion of copper. If you cannot have the ceruloplasmin, right, your copper is free to go. And if it's free to go, it gets deposited inside your liver, your brain, and that's why you see this liver cirrhosis picture. Especially it likes to involve your CNS, so that's why you see this Parkinson and dementia picture as well. It can deposit around your eyes. That's why you see this flasher rings. Okay, Kasser flasher rings. I would recommend that you see the picture of these. Sometimes they give you. And another thing I was telling you, yeah. So this is your ATP 7B gene. Okay, and the problem is with the low ceruloplasmin levels. This is the key word that you should remember. So if I ask you what is Wilson disease, the most important key word that you should remember about this disease is decreased ceruloplasmin, which means you cannot combine to copper, and which means your copper will deposit inside your liver and inside your CNS. Okay. And after this, you need to remember that on your laboratory workup, they can literally give you the lab thing, and they can say you that your 24 or urinary copper, it's more than, like, normally you do not see it, but now you will see high levels of urinary copper and no levels or decreased levels, serum levels of your ceruloplasmin. This is diagnostic of Wilson disease. Okay. And if you have mutation of this ATP7A gene, this is also related to copper, but it leads to another disease that is known as Menkes disease. This is not for today's topic. This is a biochem topic. So, anyways, just for because it's very related, I just told you. Okay, they like to test this whole thing. I have told you about the lab work also. How do you treat it? You give penicillamine. That this you have to remember. It's not similar to penicillins. Penicillins are your antibiotic. This is your you can say chelating agent. Okay, it helps with chelation. It's a chelating agent. Okay, so penicillamine. You give penicillamine, and they you can also give zinc. They tend to ask you penicillamine. They ask about zinc as a treatment, and there is another one trientine. This can also be tested. I have seen zinc and penicillamine being tested more than trientine, but I would recommend that you remember all these three. This was your Wilson disease. So I hope you guys are clear with this, and then we will do the last topic. This is your biliary cholangitis. If you guys are clear, you can just tell me.
Okay. Yes.
Yes,
Sure.
sure.
Okay.
Yes,
Yes.
sure.
Yes. Yeah. Okay. So now we have the last disorder that we will cover is your biliary tract disease. So if I say biliary tract disease, it means a disease that starts from your cystic duct, from your hepatic duct, and then your common bile duct. Okay, then your common bile duct. This whole thing is your biliary tree. Okay, this whole thing is your biliary tree. Now you have three types. If I were to say, you have primary sclerosing cholangitis, and then you have primary biliary cholangitis. Both of them can present very similarly. Both of them tend to present with jaundice, of course, because as I told you, your common bile duct, this is your liver, and this is your you can say common bile duct, and this is your second part of duodenum. If you have inflammation or obstruction here, it can lead to jaundice because what kind of jaundice would you see? You would see obstructive jaundice. So jaundice that is high in conjugated bilirubin. Okay, so you will see this thing happening, and you will see dark urine, light color stools, the everything I told you. Pruritus is also common with jaundice. It can present with pruritus too. So fatigue, pruritus, jaundice. You see this combination. The first thing that you should always keep in differentials is your biliary tract pathology. Okay. So two types: primary sclerosing cholangitis, primary biliary cholangitis. I want you to remember that primary people tend to confuse it. Don't confuse it. They actually love to test these topics because they can be confusing because they sound similar. So this is in males and this is in females. So I want you to remember, like in females we have breasts. So primary biliary cholangitis is female, and for males it's primary sclerosing cholangitis. You can think of it in this way: like males, they are very hard, like they are very emotionally hard, so they are sclerotic, they are fibrotic, they're not even living. So like primary sclerosing cholangitis, like whatever helps you remembering. I remembered in this way because it was quite difficult for me. Anyway, so your males and female thing. So primary sclerosing cholangitis more common in males, primary biliary cholangitis more common in females. Okay, they can present very similarly. What you should remember for this, what they love to ask is your antibodies. So it's your anti-mitochondrial antibodies. You know, like mitochondria, when you are when there is a fertilization taking place, like like your mitochondria is given to you by your mother, right? Not by father. So, antimitochondrial antibody would be seen in a disorder that is common in females, which is a primary biliary cholangitis. Okay, so this is very high in like for step 1, 2, and 3. I don't know why, but they like to test this antibody a lot. Antimitochondrial antibody positive in primary biliary cholangitis. Okay, primary biliary cholangitis. And then you have how does it present on histology. You see this because these are autoimmune diseases, they can always give you this is a rule of thumb for everything. One autoimmune disease can lead to other autoimmune diseases. Like if I say someone is suffering from primary biliary cholangitis, they can suffer from Hashimoto's thyroiditis too. They can suffer from, you can say, celiac disease and stuff like this, like SLE, like any kind of thing. Okay, so they will always give you this whole scenario in which they talk about one autoimmune disease, especially Hashimoto's thyroiditis, and then they talk about primary biliary cholangitis. This is one thing that these are a few points that you should keep in mind. On histology, how does it present? It presents with lymphocytic infiltrate because this is cholangitis, this is inflammation, right? So you you have lymphocytic infiltrate. Why do you see lymphocytic infiltrate? Because this is a chronic problem. This is a chronic autoimmune problem. Most of your autoimmune problems are chronic. Okay. Whenever you see acute thing happening, you will see on histology more of neutrophils rather than lymphocytes. Okay. This is another clue that can help you when you solve your question. So if you see neutrophilic infiltrate, you can think of some acute cause. If you see lymphocytic infiltrate, it's more of a chronic cause. Okay. So autoimmune diseases, most of them are chronic. So that's why you see lymphocytic infiltrate. Okay. And in this disorder, you form granulomas, and you like granulomas of this whole duct that is happening. I believe that you all guys know what are granulomas. These are your, you can say, inflammatory aggregates around your duct, okay, that lead to narrowing of your duct, and that's why you have this biliary tract disorder. You see high conjugated bilirubinemia, obstructive jaundice. Okay. Now we will talk about primary sclerosing cholangitis. For primary sclerosing cholangitis, I want you to keep this in mind. I have told you it's in males, and for this you can remember that you can also remember. Sorry, I am naming males as a bad thing, but onion skin appearance uh, is a finding for histology thing. So you can remember like onion has so many layers, so you can remember like males have so many layers when it comes to their reality. Just saying this thing, not real, just for memorization. Okay. So you can see this onion skin appearance. You have fibrosis here because it's sclerosis. Sclerosis means fibrosis. It means you collagen deposition. It means you will see strictures. Strictures is like narrowing of your duct. Okay. Strictures literally mean, like if I say this is your normal ductal volume, it can convert into something like this if the structure is there, because because inside this whole wall thing, this is the lumen of your duct, this is your lumen of your duct, this is whole wall of your duct, right? In the wall of your duct you are depositing your collagen, and that is narrowing your volume, your lumen volume. Okay. So that's why you see fibrosis and onion skin thing if you do the histology, and you have this phases, like at one area you see a lot of sclerosis, then another area you do not see, and then another area you see a lot of sclerosis. So this is also known as beading appearance. So for primary sclerosing cholangitis, what are keywords? Onion skin appearance, fibrosis on histology, bleeding appearance. Okay, and this is associated with ulcerative colitis. These are your keywords. Okay, ulcerative colitis. And if you guys have studied ulcerative colitis, you know in ulcerative colitis what kind of antibody is positive? It's with your MPO. It's your MPO ANCA. Okay. What is ANCA? Basically, ANCA is an antibody that is directed, like this is your neutrophil. Okay. This is the nucleus of the neutrophil. Okay. This is your cellular protein that is sitting there. So ANCA is basically an antibody that is directed against an enzyme that is sitting inside the neutrophil. So this is your MPO, like PNCA. Okay. Like a myeloperoxidase antibody. So PNCA, MPO NCA. Okay. And another thing that you should remember, antibody, MPO antibody for females, antimitochondrial antibody. And last but not the least thing, this disorder, primary sclerosing cholangitis, can convert into cholangiocarcinoma like a gallbladder cancer, or a ductal like a bile duct cancer. Okay, cholangiocarcinoma or gallbladder cancer, like both things can happen. So I hope this is very clear, and we are almost done with everything. Um, okay.
Okay. Thank you so much, Dr. Aliza, Dr. Aliza, for and also students also liked it, and students also liked it. So tomorrow we are going to have session on pharmacology. So another thing about our subject student named Ahmad, right? Named
He have
Ahmad, right?
nice to be out him,
Like
he have
basically,
nice to be out him, like basically
connect up with computer and also with math, right?
and
He's also
right?
from his he's also from his share his students, right? So I just promise him. I just promise him. I'll just
You're
help.
echoing. We can't really get what you're saying. You're echoing. We can't really get what you're saying.
Dr. Aliza, can you please?
Dr. Aliza, can you please?
Because we are having issue.
Uh, I cannot hear you properly.
Can you please turn off your mic? Please turn off your mic.
Yes.
Perfect. So, I basically want to tell you that we have a student. He's going to come. He's going to share his journey in a day or two. So get prepared for that as well. He's also going to guide you as well. So we have him in his journey, and we would love to hear teaching. Okay, perfect. So Dr. Lisa is going to be your tutor for the next sessions, and I'll be more focused on the revision session because it's your critical time. I think you need a lot of help this time. So as we promised that we are going to help you in every way possible, right? So thank you so much, Dr. Lisa, for having such an amazing session, and we will be sharing that within a while. Thank you so much. See you guys tomorrow. See you guys tomorrow.
Okay, see you guys. Bye. Bye, everyone.